Coleman, and I am the new director of South Carolina Safe Care. I joined the Hospital Association last week, so if I haven't had the opportunity of meeting you today, I certainly look forward to working with you. With the ideas from her inspiring presentation, Beverly Johnson will also lead our patient experience breakout session today, along with Caroline. We met Caroline earlier at the lunch, but just as a recap, she is a patient advocate and the guest services representative and staff liaison to the Family Advisory Council at the Medical University of South Carolina Children's Hospital. So please join me in welcoming Beverly and Caroline to dive deeper into the patient and family care experience.
These AV people are working so hard, and so we are going to have a conversation with you, and if you want to stay where you are, that's okay, but if we won't bite if you want to come up and have a little cozier conversation. Can you all see us if we even sit down? That may work. And does that work?
Hello?
Oh, we'll use, okay, here. Oh, okay. I'll talk a little bit and then I'll give it over to Caroline. We'll just go in a little different order. Do you don't even have the other slides.
You came and loaded them.
They're on my computer, but we moved so fast we didn't have a chance. I tell you what, this is called flexibility, right? That's part of being patient and family centered. So how comfortable do you feel, Caroline, sort of telling a little bit about your story and how you got involved in the important work you do now? And I'll go pull up some slides.
Sure.
I wasn't going to just go home and get on the plane. But having seen you speak spontaneously a moment ago, I have total confidence. So let me go see if we can.
There it is, yeah.
Oh, okay.
Okay, hey everybody. Without getting too much into storytelling, because I know we're short on time, but I'm Caroline DeLongshaw. My relationship with healthcare and with Medical University started in October 3rd of 2005. My son was 11 months old when he was hit by a car in our driveway. Car ran over his head, and so I found myself in the throes of healthcare, and that's why I'm here today. Sam was taken to the nearest emergency room where they could do nothing for him until he was transported downtown to the Medical University. He had skull, orbital, and facial fractures, too many to count, and bifrontal contusions and intracranial hemorrhage. They also originally thought that his right optic nerve had been compromised. He was triaged and intubated in the pediatric emergency department and then immediately taken upstairs to the pediatric ICU. My healthcare experience at that time had been limited to 3 normal pregnancies and deliveries, so I was pretty sure that it wasn't normal for clinicians to cry in front of patients and families. I knew we were in trouble. Just looking at him, you knew we were in trouble. Being separated once we got to the pediatric ICU was challenging. When we were separated because they were placing an external ventricular drain in his skull. Once that separation occurred, when we were brought back to the bedside, it was difficult. It's the first time I'd been separated from him since I pulled him out from underneath that tire. So being brought to the bedside, I immediately began to scan the unit for another baby that looked more like mine because I didn't like what was in bed 10. And I'm not going to get into the whole storytelling. The reason I just tell this part is because of the significance of who I saw as a powerful caregiver empowered me. And so standing 3 feet from the foot of the bed, I didn't want to be involved. But the nurse didn't allow that to happen. She engaged me. She came and she took my hand and she tucked it up underneath her arm. And as she worked, she spoke to me and she said, I need you. And he needs you, and I need you to talk to him so he can hear your voice. And while I'm working, I'm going to tell you that this blue tube is a ventilator, and it's helping him breathe. And this is a drain. It's pulling the blood off of his brain. It's measuring the intracranial pressure. It's the purple line on the bottom. It's going to get between these numbers. We don't want it to get too high. We don't want it to... and so forth and so on. And while she did that, she pumped my hand, sort of as if to say without language, you're not going down, and we're in this together. I'm with you, is what her body language said. I'm with you. And so, again, a very powerful person to me because she empowered me in the most compassionate way under the most stressful circumstances and empowered me to be a part of Sam's care. So I think that that was a pivotal point for us in what happened. And it's a great story. It's a long story, and we're not going to get into all of it, but it's probably what brought me here with you today.
And I hope you will take that story, because so often I think in healthcare today, there's pushback that we can't do this. There isn't time. And when you told that story to me last night, and again hearing you say it today, the nurse reached out to you and connected with you, brought you into the situation, and then while she was doing clinical things, was talking out loud to help teach you at the same time. It's not like, oh, we're now going to have a little session over here that is about education. But she was, and I think it is a safe practice because it's reinforcing on many levels for her, but also very much you were included in that from the beginning. So we have just a little bit of time together. So we brought some slides, but we also want to hear from you about, are there some key questions that you have for Caroline and me about improving the experience of care? We've brought some slides and we can talk about those, but we want to just make sure that if there is a pressing hot topic that you want to make sure we cover, that we cover it. So anybody want to shout out something, or we'll just proceed? It's hard to see with the bright lights on, but is there anyone that has something that you want to make sure we talk about? Well, I tell you what, oh, good. I can't see you because you're right in front of the bright light. Yes.
I'm looking for recruitment strategies. We have a very active patient-family experience council. A little bit of resistance on putting them on the RCA teams yet, but I need to recruit the right people moving forward. So I need
Sure.
more any advice.
Great. Well, let's just take that question. One thing I would comment on right away is I think it's really important for people to earn trust and skills on both sides, so that I don't think we should race to get somebody on an RCA. I think there are lots of steps before that where you learn more about it, and I worried a little bit nationally with some of the efforts. They were saying just put a patient on the board, and I don't think they had the kind of experience that they need. So let's talk a moment about recruitment. And do you want to start with that? Do you have some ideas about recruitment, Caroline?
I think it's all about building relationships. So when Bev was talking about how important those staff liaisons are, I think until there's that education about what patient and family centered care is and what those liaisons are responsible for in your organization, it can be very challenging. We're very blessed to have the chair of our Family Advisory Council is not afraid to speak up, and in a meaningful way. It can be in a positive way, but not afraid to speak her mind. Those are important things, not being shy, but also being respectful at the same time, and being an integral part of the organization. And therefore, she's been asked to serve on executive committee, operations committee. Her opinion is very well respected and trusted because they trust that she's going to be purposeful and meaningful and respectful.
I've seen some places, I think clinician staff, peer support programs are wonderful places to go and look for advisors. And to take some of those qualities that Caroline just talked about, I've seen them put it on a postcard, and to make it easy for someone to say, you know, dear Mrs. Jones, I think you would make a wonderful patient and family advisor. We have a program where you go through an interview process and a selection process, but they are making a tremendous difference in our hospital, and I would like you to consider it. Patients feel very flattered to be nominated by their physician, but it's important to know that you're being recommended to be considered so that there is a selection process. And but if you make it easy for frontline nursing staff, for nurse practitioners, for physicians to nominate people, I think that's a very good way of doing it. I think we see the most
And that they see
coming
the
from.
importance of, it's important our advisors understand the importance of storytelling, but the biggest thing is being able to see beyond your own story. So again, I can't say enough, my story is important, but I have to be able to see beyond my own story for the greater good. And if someone is stuck in their own story, and only how it applies to them and their experience, it's not gonna benefit the greater good. But our nurses and staff have I think, a good, can build a good rapport. And so my being able to build a good rapport with the staff is really important because that's where our recruitment comes from, is my relationship, at least in Children's Hospital, with the nurses, the physicians, techs, whoever it may be, those child life specialists that do build a rapport on a daily basis with the patients and families.
Is there another question that you have about, so you have a patient experience council, so, and there are patients and families on it as well as others. What you want to do in your committees and teams that you bring patients and families on, you want to make sure that there's not just one patient and family. It becomes a token. And it's really intimidating to be the only patient and voice, and if you're not there, and it almost gives permission for clinicians and staff to say, see, it doesn't work. And then it's much harder to restart it. But I think to have in a group of, say, 9 or 10, that you have 3 patient advisors, and even prepare an alternate so that you keep a significant voice in the conversations. I'm going to skip and show just a couple of slides, and then, because I want you to hear some of the stories of the work that Caroline is doing in her organization. You know, I think that the leaders have to say it's important that we partner with patients and families, and to say we're not going forward with the project unless their patient's part of the process. But I think you need to invest in leaders learning about patient and family-centered care to really understand how to move it forward in their organization. I think another key point that I didn't make in the earlier session was that there ought to be an executive champion. It may be your chief medical officer. Maybe it's your chief nursing officer. Some of your organizations, it's the CEO or the COO. But some executive leader who's saying this is important, and it will help open doors, and these people can help address barriers and challenges when you bump into them. We have lots of resources available at the Institute, and I shared with you our website. The book there in the middle with a jump drive is the book for staff liaisons. And 40 different people in Caroline's position helped us write this, and the flash drive has tools that you don't have to reinvent the wheel. They have an application form. You can put your logo on it and you can change it. So there are 200 or 300 tools like that on that flash drive. What are simple ways to get started? Because before they serve on that RCA, you know, maybe do some things that are not too threatening. Caroline's group has gone a little further, and she's going to share with that in a minute, but I thought I'd give you a couple simple ideas if you're getting started. Maybe I should ask, how many of you have patient and family advisors really significantly involved now? But not too many. So, okay, we'll continue with participating in a walkabout and looking at your hospital together from the perspective of patients and families, and I'll come back to that in a second. Maybe bringing them together and just brainstorm, what would the ideal healthcare look like to you? We've done this many times in many places as the first thing that groups of advisors do together. You can even do it with a community group as you think about whether some of those people might become advisors for you. And just brainstorm, what would ideal healthcare look like? You may not be able to do all of that, but it gets people thinking and creative, and it can be a whole lot of fun. Same thing if you're working in the patient-centered medical home. What does ideal ambulatory care look like? Another project that you could have is to make sure that every one of the first impressions in your healthcare organization is positive and welcoming. What is it like when you call in on the telephone? I can think of some clinics that I am so intimidated and so frustrated and so angry before I get to a human being. And I'm thinking, no wonder they don't like to work with us, because we're not at our best after waiting on the phone like that. But what's the front door look like? What's the road from the parking lot into the front of your hospital? As you get off of every single elevator, what's the first impression? What's the first impression when they go in your ICU, or they go on the med-surg unit, or they enter the emergency room? Those are things to think about, because you gradually change the culture for both patients and families and for healthcare professionals. Look at your website. I had quite a journey last night on lots of people's websites, so I'm hoping you're going to go back and look at your websites and see if it in fact is consistent with patient and family-centered care and are really welcoming to patients and families. And then planning new construction and renovation. Sometimes people are less resistant to have them part of that than changing a clinical practice like nurse change a shift or rounds. So, with a walkabout, patients and families sometimes see it differently, so do it with your leadership and your frontline staff and patients and families together, and take pictures, do the before and after, because you'll probably come back and make lots of changes because of it. Another thing to do together is to do an assessment. And the Better Together has a simple 2-page, we even have it online, to do an assessment on how you're partnering with patients and families. Now, I asked Caroline last week just to send me a few ideas about what they were doing with patients and family advisors. And I was just blown away by all the neat things. So she's going to tell you about a few of these, and click it when you're ready.
And something you said reminded me too is that, and I say this a lot, but when you get off the F elevator in the Children's Hospital on the 8th floor, it's 82 steps from the elevator to the pediatric ICU doors. And I used to walk those 82 steps multiple times a day with horror, with fear. I can remember the smell. I can remember the sounds around me. And then you get to the end of the 82 steps, and you have to either, at the time I was there, pick up a phone or ring a buzzer and wait for someone to answer, and wait for someone to answer. And all the while, your child is in critical condition, and you never know if the next moment is going to be the last moment. And then one day you're greeted with the voice saying, you can't come in, something bad is happening. And you don't know if it's your child or another child. And so now I take those 82 steps every day, but instead of going straight to the unit, I'm going to my office, which is right outside the ICU. And I'm ashamed to say that sometimes I forget. Sometimes I forget that that's someone else's worst day, and that they're smelling those smells and feeling those fears and horrors the way I did. And so I get it now, being on the other side. We can't always walk through the footsteps of our patients and families. We don't have to feel what they're feeling to be able to exhibit empathy and compassion, but certainly try and remember it as best we can. So some of the few things that we're doing at the Children's Hospital right now, the biggest thing is that we are in the midst of building a new building. It's our phase 2 project for the new Children's Hospital and Women's Pavilion, and we're most proud to say that we have created clinical teams, and on each clinical team for every area of the hospital, we have a nurse and a physician lead, but we also have a parent that's representing that area. So our parents are heavily involved in every area of the new build with the units that their children have been on, which is a really cool perspective, and the fact that the hospital recognized that, and the leaders in our hospital recognize the importance of the patient and family perspective.
Do you want
Should I
to
give
tell
the
about
example?
that? Yes.
My favorite example of that,
Let me ask you a quick question.
sure.
Parents, how long do they stay involved? If you get a parent that gets connected to you for whatever reason, you recruit them, how long, what's the lifespan?
Oh, you mean for like a PFAC?
For the volunteer?
For the Family Advisory Council? Well, it's interesting because we're in the midst of a project that's looking at that right now. For the Children's Hospital PFAC, we haven't had term limits yet in our guidelines. We may be about to have term limits. So far for us, there seems to have been a natural ebb and tide with that, that those who serve. What I would like to see is that eventually we create a structure, and so that once you have served for whatever X number of years, then your service could maybe roll into being a member of our family faculty, which right now is non-existent, but maybe would be one day. Mm-hmm. So it would be another elevation in order which they can serve. I have members of our Family Advisory Council that have been there since '05 that have chronically ill children that are frequent flyers, and their experiences are valuable, just as valuable today, if not more, than they were when they first started with us.
I think Carolyn is right that it's best practice would be to have things you could do before you become a council member. There are committees and projects and teams you could be on. Then you could be on the council. Typically, people have 2 to 3 year terms and serve 2 or 3 terms. Then they go do other things and then they come back. But you just don't want to burn them out. I have seen with many places, and South Carolina is a wonderful place to retire, that we've not tapped into the retirement community the way we can. And I know many advisors people who are retired that bring their life experience and now their healthcare experiences and are loving it. And the healthcare professionals say, oh, we don't want to be a burden. They can only come, once a month for 2 hours. They're coming 2 and 3 days a week. And it is the reason they get up in the morning.
And the reason I think they keep coming back is because it's meaningful work. So our stakeholders are at the table. This is not a support group. This is administrators, leaders, nurses, physicians, neonatologists, hospitalists that all sit on our council, so that we're not talking about something, going away for a month, and then coming back and trying to make it work. Those decision makers are at our table, which is the key. The key. But the story I wanted to share is about one of our pediatric cardiology moms who has incredibly given her service on our Family Advisory Council. They lost a child, but she has come back now, and she's no longer serving on the PFAC, but she is serving on one of our clinical teams in the new build. There was a discussion in one of the design meetings. We were in the middle of schematic design, and as a discussion came up about walls versus no walls. So we're moving to private rooms, all private rooms in our new hospital, which is very scary for some of our ICU docs that are used to having, at least in our pediatric cardiology unit, we have some private rooms, but we also have some open units, which they like because they can see the babies from the nurse's station and from workstations. So there was a discussion that evolved about walls versus no walls. This particular mom wasn't able or brave enough at the time. Sometimes she said it takes her a while to compose her thoughts. It took her a couple days, and she came back later with an email. And it was the most beautifully written email about the importance of walls. And just to synthesize it a little bit, she said when we were in an open bay without walls, I couldn't cry. I didn't feel like I could nurse. And I couldn't play music for my daughter because I didn't want to disturb the baby who was next to us, which was only about this far away. So, that's no privacy at its best, right? But as her daughter got worse, they were put in a private room, and all the rules were broken. As many people that wanted to come in were able to come in and visit, to be with Maya. And those walls gave them the opportunity to be a family, and were meaningful beyond anything that I could ever convey to you in this room. But they allowed their family to be a family while their daughter was taking her last breaths. When I received this email, we then had another organizational meeting that did not involve families for that particular unit. And I ran to the meeting, and I had the email in my hand, and I thought, I'm going to ask permission if I can read this letter before they get started on their work and continue this discussion, important discussion about walls versus no walls. But before I could even raise my hand, the cardiologist that was in charge said, before we get started, I have an email I'd like to read. And he read her email, and you could have heard a pin drop in that room. And he was a cardiologist who was opposed to having walls. And he simply said, the discussion of walls versus no walls is done. So the impact that a family advisor can make is never underestimated. So we're really proud of that and the work that's being done there.
And I think it's really important to celebrate that and to put that in the history of your council. And so every little thing where you see where they help us really change our thinking is important to help build understanding that this partnership work is essential to to the work we do.
When they created the mission statement for the new hospital, the mission statement involved the wording that was, we would support patients and families in this new environment. And so they took our constructive criticism and said, instead of supporting, doesn't it feel different to say partner with? It's one thing to support, but it's another thing to partner with, and that's a better verb, we felt like. And we also adopted Maya Angelou's quote with our new build project. And so in every meeting, we sort of remind ourselves as we go to designing this new facility that it's not, people will forget what you said, people will forget what you did, but people will never forget the way you make them feel. And so we are talking about that now, and we've been talking about it, and some of our managers have even posted it in their units just to get ready. We're not doing this just for the new construction and the new build. We want to practice this way now. And that's coming from our Family Advisory Council as well.
Want to move to another?
Yes,
Yeah.
definitely. What are some of these key things do any of these look exciting to y'all that you, we have family advisors that sit on every single children's hospital committee that we have, including our executive committee and operations, parent satisfaction, patient satisfaction rather, and NICU parent satisfaction. It changes the conversation. In those meetings, you have everything from physicians to PTs, OTs, dietary, but when our parents walk in the room, it definitely changes the conversation for the better. The family presence guidelines in the ICU. Our administrator asked me to look at our family presence guidelines, but we called them visitation at the time. And so I but I cover the neonatal ICU and the pediatric ICU. That's where I spend the most of my time. I also cross-cover in the pediatric ICU, pediatric cardiology ICU. So I have relationships with the people in those areas. And so learning about the way they practice, standardizing our ICU guidelines across the board didn't really seem to make much sense. It's important for me that the staff knows that I respect the way they have evolved and the way they practice, as well as looking at what's best for the patients and families. So our ICU guidelines have been a work in progress, but I think the biggest progress we've made is the last group to get to is our NICU group as far as being present for change of shift. It wasn't so effective. I mean, our administrator is great and very family-centered, but sometimes it doesn't work when you walk into a staff meeting and say, you will allow families to be present during change of shift. That didn't work, and they didn't like it, and they looked at us and said, we ain't doing it. So it's taking some time to sort of regroup, because they'll show us literature that says it's not safe, and that mistakes could be made. But what we want to encourage is that this would be a missed opportunity to partner. And so the biggest fight is about that HIPAA. It's a HIPAA violation, because the mom next door can hear what's going on. And so our point is, it's all about managing expectations. So if we're able to talk to the families at the beginning, and manage their expectations and explain what change of shift looks like and what's going on. And if we explain to them and repeat, because I know as a parent I need to hear it more than once, that during these sacred hours, 7A and 7P, every day, this is a sacred time when we're exchanging information for the safety of your child. We want you to be here, we want you to participate, but if you could just wait till the end to report and then ask any questions, write down any concerns you may have, and we'll address them at that time. There are ways to manage it, and we have to practice doing it before we can say we're absolutely not going to do it.
And so we're going to have to draw this session to a close, but Caroline and I are both here, and we're happy. They're going to be setting up the technology, et cetera, for the closing session. But I just want to comment briefly on the sensitive area that Caroline is talking about, that it's really important to respect your frontline staff, to support them in this kind of process of change. You're right that just saying you will now do it doesn't convey that kind of respect. But it's helping people understand and really understand the data, because I think overall you will see that the data, particularly with HIPAA, that denying access to information, if you're not there during report, you're cutting off information, and that you've got to balance that with privacy. So it has been demonstrated over and over again that you can do this. It is not a violation of HIPAA, but we have to support staff and help them get through this change. I have a few more slides that we were planning to show, but they're going to be posted. So thank you for your attention, and we are happy to answer questions or show anything to you and talk more about it before the 4 o'clock session. So thank you very much. Thank you, Beverly.